Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about basal cell carcinoma. Definition: basal cell carcinoma is a malignant neoplasm arising from the basal cells of the epidermis. Although these cancers rarely metastasize, their potential for local destruction attests to their malignant nature. UV radiation is the cause of most basal cell carcinomas in humans. Four clinically and histopathologically distinct types of basal cell carcinoma are recognized: nodular, pigmented, superficial, and scarring or sclerotic basal cell carcinoma. Incidence: basal cell carcinoma is the most common human malignant disease. It affects more than 2 million persons annually in the United States. The increased frequency in adults with light skin is related to sun exposure. Basal cell carcinoma is the most common skin cancer, but it is very rarely metastasizes. History: the patient with basal cell carcinoma seeks medical attention because of a new growth, especially if it is a non-healing, easily bleeding lesion. There may be a personal or family history of skin cancer. The risk of basal cell carcinoma is higher in patients with light skin, in those who live in southern latitudes, and in those who work or play outdoors. Frequently, these patients have a history of sunburning easily and turning pearly. While it can happen, it is very uncommon in dark-skinned individuals. Physical examination: the usual patient with basal cell carcinoma has fair skin, blue eyes, blonde or red hair, and actinic damaged skin manifested by freckles, yellow wrinkling, and actinic keratosis. Basal cell carcinoma occurs in sun-exposed skin, particularly the head and neck. The nodular type of basal cell carcinoma is the most common. It is a pearly, semi-translucent papule or nodule that often has a central depression or crater, telangiectasia, and a rolled waxy border. Ulceration and crusting can occur. Nodular basal cell carcinoma occurs most frequently on the face, especially the nose. A pearly appearance is the most characteristic feature of a nodular basal cell carcinoma. Here we can see nodular basal cell carcinoma, and we have also basal cell carcinoma in diagram B. Epidermis: in epidermis we can see thickening. In dermis we have invasive bars and lobules of basaloid cells. Basal cell nevus syndrome. Basal cell nevus syndrome is a multiple pearly to flesh-colored papules and nodules with a rolled border and telangiectasia and some crusting. We will explain about it later. Pigmented basal cell carcinoma is a shiny blue-black papule, nodule, or plaque. The pigment is often speckled, and a pearly rolled margin can be seen when the tumor is viewed from the side. This is the most common presentation on dark skin. Here we can see pigmented basal cell carcinoma. We have black, slightly scaling, and translucent plaque. Superficial basal cell carcinoma occurs most frequently on the thorax. It is a red, slightly scaling, well-demarcated, eczematous-appearing patch. Centrally, it may become slightly eroded and crusted, subsequently leaving an atrophic, slightly depressed center. Its shape is oval to round with a characteristic thread-like pearly rolled border. It is often referred to as an multicentric superficial basal cell carcinoma because it skips islands of normal skin, similar to the way the forest fire may surround a stand of trees yet leave it unburned. Here we can see superficial basal cell carcinoma. We have a red, slightly scaling, and crusted patch. The scarring or sclerotic or Morpheaform basal cell carcinoma is an atrophic, white, slightly eroded or crusted plaque that often looks like a scar. It is frequently depressed and is the least common and most aggressive type of basal cell carcinoma. Here we have the scarring or sclerotic or Morpheaform basal cell carcinoma. We have pink, atrophic, white, slightly crusted, ill-marginated patch. Differential diagnosis: nodular basal cell carcinoma and sebaceous hyperplasia are sometimes difficult to differentiate clinically. Sebaceous hyperplasia is the proliferation of sebaceous glands surrounding a hair follicle that appears as a 1 to 3 millimeter yellowish pupule with overlying telangiectasia and a central pore. The yellowish coloration and central pore help to differentiate it from a basal cell carcinoma. Other epithelial growths that resemble a nodular basal cell carcinoma include a non-pigmented nevus molluscum contagiosum, Merkel cell carcinoma, trichoepithelioma, fibrous pupule of the nose, lichenoid keratosis, and squamous cell carcinoma. Pigmented basal cell carcinoma can be confused with a seborrheic keratosis, pigmented nevus, and most importantly, malignant melanoma. The parallel border of pigmented basal cell carcinoma helps to differentiate it from a malignant melanoma. If doubt exists, an excisional or deep shave biopsy should be performed. Superficial basal cell carcinoma resembles a patch of dermatitis. It can be confused with psoriasis, nodular dermatitis, and squamous cell carcinoma. A persistent solitary lesion and lack of response to topical steroids clinically differentiate superficial basal cell carcinoma from dermatitis or psoriasis. A skin biopsy is the only way to differentiate it from squamous cell carcinoma in situ. Any non-healing scar-like lesions should undergo biopsy to rule out a scarring basal cell carcinoma. The conclusion of differential diagnosis of basal cell carcinoma. The differential diagnosis for nodular basal cell carcinoma are sebaceous hyperplasia, flesh-colored nevus, molluscum contagiosum, Merkel cell carcinoma, trichoepithelioma, fibrous pupule of the nose, and squamous cell carcinoma. And the differential diagnosis for pigmented basal cell carcinoma are seborrheic keratosis, pigmented nevus, malignant melanoma, and for superficial basal cell carcinoma, dermatitis, lichenoid keratosis, squamous cell carcinoma, and for scarring basal cell carcinoma, the differential diagnosis is scar. Laboratory and biopsy. The diagnosis of basal cell carcinoma should be confirmed by a shave or punch biopsy. The tumors are made up of uniform cells that resemble the basal layers of the epidermis. They have a uniform large oval blue nucleus with indistinct cytoplasm. The tumor extends from the epidermis into the dermis as a nodular or cystic structure, bands or strands, or as buds from the epidermis. The nodular areas have peripheral palisading with retraction from the surrounding stroma. The cells in some basal cell carcinomas have a squamoid appearance, which makes them difficult to differentiate from squamous cell carcinoma. The infiltrative Morpheaform, micronodular, and mixed histologic subtypes of primary basal cell carcinoma are more aggressive and more difficult to eradicate. Here we have basal cell carcinoma. We have basaloid tumor arising from the epidermis. We have nests of basaloid cells with scent cytoplasm and elongated hyperchromatic nuclei. We have peripheral palisading. We have myxoid stroma, and we can see also peritumoral clefting. Therapy. Sun protective measures such as the use of sunscreens, protective clothing, and avoiding midday UV light exposure are crucial for preventing future basal cell carcinomas. Nicotinamide 500 mg twice a day is also effective in reducing basal cell carcinoma. Treatment of basal cell carcinoma should be individualized according to the location of the lesion, the histopathologic type, the age of the patient, the general health of the patient, the size of the basal cell carcinoma, and whether it is primary or recurrent. Recurrence of basal cell carcinoma is related particularly to location on the nose or ear, size more than 2 cm, and histologic pattern of micronodular, infiltrative, and morphic type. Treatment modalities include scalpel excision, cortage and electrodesiccation, radiotherapy, cryotherapy, and topical 5-fluorouracil or imiquimod. Each treatment must be properly selected to achieve a high cure rate. Surgical modalities are those most frequently used and have the best cure rates. Excision with primary suture closure, the most frequently used form of therapy, allows for histologic assessment of surgical margins. When the wound is large, grafts or tissue transposition flaps may be used to achieve closure. Excision is good for most basal cell carcinomas, but is the treatment of choice for large basal cell carcinomas, recurrent tumors, sclerosing types of basal cell carcinoma, basal cell carcinomas at sites of high recurrence, such as the nose or ear, and basal cell carcinoma that extends into the subcutaneous tissue. A specialized form of excision using detailed mapping of the extent of the tumor, which histologic orientation is the most micrographic surgical technique. This meticulous procedure is most often used for basal cell carcinomas on the head and neck, recurrent basal cell carcinoma, and primary tumors with a high risk of recurrence. Most micrographic surgery has the highest cure rate and preserves the most normal skin. It is indicated for most facial neck basal cell carcinomas and for recurrent basal cell carcinomas. Cortage and electrodesiccation is a therapeutic modality frequently used by dermatologists. The clinical margins of the tumor are defined by vigorous cortage until the firm fibrous consistency of normal dermis is felt. This is often followed by electrodesiccation. The entire procedure of cortage and electrodesiccation may be repeated to ensure the removal of the tumor. The resultant wound heals by secondary intention over a 2 to 3 week period with excellent cosmetic result in most cases. Experience is needed to obtain good cure rates. Cortage and electrodesiccation should not be used for basal cell carcinoma with poorly defined clinical borders, for sclerosing basal cell carcinomas, for recurrent basal cell carcinomas, or in certain anatomic locations such as the nasolabial fold and eyelids. Radiation therapy is reserved for elderly patients because the subsequent chronic radiodermatitis that occurs years after the therapy may be cosmetically unacceptable, and because of the potential for developing a new primary cancer in the radiotherapy site. Radiation therapy is used when the patient refuses surgical treatment or has a large tumor that would be difficult to treat surgically. A cryosurgery with liquid nitrogen is reserved for those clinicians experienced in its use for cancer therapy. The margins and depth of the tumor must be estimated clinically. Cryoprobes are used to monitor the depth of the freeze. After surgery, marked tissue reaction occurs with edema, tissue necrosis, weeping, and crusting. Topical chemotherapy with 5-fluorouracil or imiquimod is in general inappropriate for treatment skin cancer. It should not be used on deep or recurrent tumors. It is occasionally used in patients who have multiple superficial multicentric basal cell carcinomas that otherwise would require numerous surgical procedures. Treatment is continued for weeks until marked inflammation and erosion occur. Residual areas suspected of having a tumor must undergo biopsy, and another therapeutic modality must be used if basal cell carcinoma persists. Wismodegib and sonidegib are hedgehog pathway inhibitors targeting smoothen or SMO. They are indicated in the treatment of locally advanced multiple or metastatic basal cell carcinoma. Serious adverse side effects including birth defects limit their use. Cemiplimab, a programmed death receptor 1 or PD-1 blocking antibody, is indicated for patients with locally advanced basal cell carcinoma previously treated with a hedgehog pathway inhibitor or for whom a healing pathway inhibitor is not appropriate. Prevention of further sun-induced damage to the skin is mandatory. Sun protection includes the regular use of sunscreens with an SPF of 30 or greater, protective clothing like wide brim hat and long sleeve shirt, and avoidance of midday sun from 10 a.m. to 2 p.m. The conclusion of therapy for basal cell carcinoma. Prevention like sunscreen with SPF 30 or greater reapply after a couple of hours. broad-brimmed hat, long-sleeved shirt and pants, and avoidance of intense midday sun from 10 a.m. to 2 p.m. and nicotinamide 500 mg twice a day. Initial therapy include excision, curettage, and electrodesiccation, most micrographic surgery, and alternative therapy include radiation, cryotherapy, 5-fluorouracil or imiquimod topical for multiple superficial basal cell carcinomas, wismodegib and sonidegib, and immunotherapy. Course and complications. Because its course is frequently indolent, a basal cell carcinoma is often ignored. It may enlarge locally and can invade underlying tissue, resulting in significant morbidity and mutilation. Vital structures such as eye, a nose, or an ear may be totally lost. Basal cell cancer rarely metastasizes. Basal cell cancer rarely metastasizes, presumably because of stromal dependence. The metastatic rate is estimated to be less than 0.003% or 1 in 52,000 cases in one series. The excessive large, ulcerated, locally destructive, and recurrent basal cell carcinoma is most likely to metastasize. Regional lymph nodes, lung, and bone are the most likely tissues involved. Routine follow-up every 6 to 12 months of patients with basal cell carcinoma is recommended because 35% of these patients will develop another basal cell carcinoma within 5 years. Pathogenesis. The most common factor related to the development of basal cell carcinoma is UV radiation. Other factors to be considered are arsenic ingestion, genetic predisposition, X irradiation, and chronic irritation. Mutations of the genes SMO and PASH or PTCH in the hedgehog pathway are implicated in our 90% of basal cell carcinomas and in basal cell nevus syndrome. Basal cell nevus syndrome is a rare autosomal dominant disorder characterized by early development of multiple basal cell carcinomas, Josse's, macrocephaly, palmar and plantar piece, increased risk of medulloblastoma and other congenital abnormalities. The origin of basal cell carcinoma is a pluripotential primordial epithelial cell in the basal layer of the skin, or less often a cutaneous appendage such as the hair follicle. Clinical case. A 72-year-old man presents with a slowly enlarging lesion on the left side of his nose that has been present for over a year. He reports occasional bleeding after washing his face, but no pain. On examination, there is a pearly flesh-colored nodule with telangiectatic vessel on its surface and a central area of ulceration with rolled edge. There is no regional lymphadenopathy. He has a history of extensive sun exposure. Which of the following is the most likely diagnosis? A. Actinic keratosis. B. Basal cell carcinoma. C. Squamous cell carcinoma. D. Seborrheic keratosis. And E. Malignant melanoma. According to our explanation, the correct answer is B, or basal cell carcinoma. Explanation: basal cell carcinoma, BCC, is the most common skin cancer, strongly linked to chronic ultraviolet exposure, as we explained above. Typical presentation: a pearly papule or nodule with telangiectasia and central ulceration, or called rodent ulcer. Common size include face, nose, ears, and neck. Slow growing and locally invasive, but rarely metastasizes. Differential points: actinic keratosis is flat, scaly, erythematous macules and are usually premalignant. Squamous cell carcinoma is ulcerated or crusted lesion, may be painful and indurated, and seborrheic keratosis is a waxy, stuck-on lesion, and malignant melanoma is pigmented lesion with color variation and irregular borders. Okay, this was an explanation about different types of basal cell carcinoma. Thank you for your attention.